Assalamu alaikum wa rahmatullah. Welcome everyone to our second day of patient safety in healthcare facilities webinar. So as we have discussed partially yesterday, that one of the issues in regard to patient safety is the overdiagnosis, and we'll continue on discussing this further today. So the most of the emphasis in the area of the diagnostic error has been in the misdiagnosis or the wrong diagnosis. But there is also a problem with overdiagnosis as well in regard to the detection of the abnormalities that will never cause symptoms or even death during a patient's lifetime if this problem was untreated. So this problem may be accelerating because of the growing availability of the highly sensitive diagnostic tests to identify the small lesions, mostly such as tumors, but also partial vascular blockage, blood clots, and other lesions whose clinical importance is still unknown. And because doctors don't know which patients are overdiagnosed, a researcher has found that working to help with this issue in the patient safety map, as we tend to treat all issues regardless of their severity or their importance. Such as, for example, we are diagnosing many more cases of cancer in regard to prostate and breast cancer than compared to the past. And due to the widespread of the use of highly sensitive techniques and screening methods, this has resulted in more diagnostic cases than in the past. And while it is not of certain that aggressive treatment of these early cancers is leading to an improvement in the overall outcome, it is also undoubtedly leading to some cases of harm in regard to these cases. And similarly, the incidence of pulmonary embolism is rising in these days. This is probably due to the remarkable ability of the computed tomographic pulmonary angiography to the small finding that can be detected and potentially of clinical and important emboli. Also, there is another issue in regard to the overdiagnosis, as diagnoses that previously were largely unknown, such as restless leg syndrome, fibromyalgia, and low testosterone level, for example, has become more common these days after the pharmaceutical companies developed the treatment option or drug therapy for these diseases. Therefore, people or patients are more encouraged to contact their doctor about this condition in order to treat them. Also, a researcher can call this condition as the disease monoemerging, and it is likely that it adds to the toll of overdiagnosis and overtreatment that is occurring currently. So, in a perfect world, the patient would stay in one place during their stay at the hospital and can be cared for by a single set of doctors and nurses. But this is actually not the case, as to come to think of it, who would want to such a world as the patient who gets sick require multiple doctors for their treatment and most likely in different facilities? And a major issue of this, as we have touched on yesterday briefly, is the issue with the handoff, which is the process of transferring a patient from a primary authority of responsibility to another, whether this was from one department to another, from one ward to another, or from a hospital to another one. And as we all learned as when we played the game of the telephone as kids, handoff can become with the responsibility of losing or missing some important information. So, where it is possible that fresh set of eyes or circumstances might offer a new perspective that will benefit the patient, as our purpose here is not to explore the optimistic scenarios, but to explore possible issues which can affect the patient's safety. And in fact, handoff and transitional errors are among the most common and consequential errors in a healthcare facility. So the 2003 limitation in the residency duty hours has led to reduced number of doctors in their shifts and longer shift hours, which has resulted in more transition or handoff of the patients between one doctor to another. And perhaps as a result of this, the last several years have been seen a growing body of evidence regarding the ways to mitigate the harm that has historically accompanied the issues of handoff or patient transition. So, healthcare is a chock full of two kinds of transition and handoff. The first one is patient related, as these patients move from one place to another within the same healthcare system, either within the same building or from one location to another. While the second are the provider related handoff, which occur even when the patient is in the same place, but this is transitioning from one team of medical doctors or another team. So both kinds of hands-off are fraught with hazards. So for example, one study found that about 12% of patients can experience a preventable adverse event after a hospital discharge, and most commonly medication-related errors. And part of the problem is that nearly half of all discharged patients have test results that are pending at discharge, and many of them, more than about half in one study, has fallen through the cracks without detecting all the results as this was pending during the discharge. And in another study, researchers surveyed that medical and surgical residents, most of whom cited inadequate sign-outs and non-standard signed-out practice as causing the patient harm, which has especially occurred when these handoffs took place over the phone or with frequent interruptions. Also, in one multi-center study, it demonstrated that the implementation of a standardized handoff bundle across the 9 residency program resulted in about 20% decrease in the medical errors and 30% decrease in the preventable adverse events. This further supports the importance of standardization, which is a prospective cohort study finding that the use of web-based handoff tools has led to a statistically significant decrease in the medical errors, especially those that are caused by failure in the communication and inadequate handoffs. And even if we grant that some transitions are necessary, one might be reasonably asking whether this healthcare needs to have quite so many of them. And the answer to this is probably yes. As research has demonstrated that patients appear to suffer from more harm when their nurses work in longer shifts, longer than 10 hours, as compared when the nurse is working in 8 to 9 hours. So this issue may be more complicated than the shift length alone. And even though that one classic study has showed that intensive care unit residents can make fewer errors when they work in shift averaging of 16 hours instead of the traditional 30 to 36-hour shift. Also, a more recent study of surgical residents showed improved satisfaction with the continuity of patient care and handoff in the group that didn't have to adhere to strict limitation on the shift length and also the time off between the shifts, even though that both groups in the study were limited to the same number of total hours per week. But unfortunately, in a 24-hour hospital, the shift limits and their associated handoff are considered as a necessity, and the shift hours cannot be changed. And even though that some might wistfully long for the day when the family doctor cared for the patient in the office, the emergency room, or the hospital, and possibly the operating and delivery room, most of the patients now expect care to be provided by a variety of physicians, such as emergency room provider, surgeons, and hospitalists, depending, of course, on the site of care. And as these specialists become involved in the patient care, they can create transition and the need for accurate information transfer. And so too does the patient clinical need to escalate the level of care, such as transitioning from hospital floor to step down unit, or the economic realities that often drives the de-escalation, such as hospital skilled nursing facilities. Also, the presence of all of these handoff and transition can make it critical to consider how information is passed between the providers and the places. And it is catalyzed in part by the mandated reduction in the resident work hours in the US that began in 2003. Also, there is an increased pressure from coming from the policy arena as well to reduce these shift hours. As in 2006, the Joint Commission has issued a national patient safety goal which required that the healthcare organization to implement a standardization approach to the handoff process communication, including an opportunity to ask and respond to questions. Also, the spirit by the studies has demonstrated a staggeringly high 30-day readmission rate in the medical care patients in about 20% overall, where 30% were patients with heart failure. Also, the medical care began financially penalizing the hospitals that have a high readmission rate in 2013. We will be taking a quick break for صلاة العصر وبعد إن شاء الله we'll continue our webinar. Assalamu alaikum wa rahmatullah. Welcome back, everyone. We'll start now by discussing the best practices for the person-to-person handoff process. First of all, like many other areas of the patient safety, the search for the best practice in handoff has led us to examine how other industries and organizations move information around their facilities. So this search has revealed several elements of effective handoffs. An information system, which is a predictable and a standardized structure of the robust interpersonal communication process. So, in one particular memorable example is the physicians at London Great Ormond Street Children's Hospital study, where they studied the Formula One motor racing. In practicality, the pit stop crew were switched out of the car tires and filling the tank with gas, cleaning the vents, and then sending the vehicle back to the road. So this was examined for lessons in how to do effective handoff process in a healthcare facility. The difference in the approach is the spike stop crews and the surgical teams that were striking. And inspired by this study, the human factors expert and re-engineered the way that the team performed their post-operative handoff process. And the new model has resulted in a significant decrease in the handoff errors, where the Joint Commission has expectation included interactive communication, up-to-date and accurate information with limited interruption, which is a process for verification, and also an opportunity to review any relevant historical data. And while the written sign-out can take a variety of forms, there is an increasing recognition of the advantages of a computerized sign-out system. This rollout over the traditional index of the card, such as a web-based handover tool describing in the study by a researcher called Malwar. So the computers and are considered as essentially part of the answer, but they are not the only part, as even in the healthcare system that have an advanced computerized record, person-to-person communication remain both necessary and potentially error-prone, therefore should be monitored carefully. So one study of an internal medicine resident sign-out has found the omission and the mischaracterization in merely 1 in every 4 information transfer process. So in a civil and military aviation field that is like the healthcare system depend on the accurate transmission of information, that is so-called a phonetic alphabet is often used during the voice communication to ensure accurate transformation of information. So in this system, a standardized word substitute for a single letter such as alpha for A, Bravo for B, or Charlie for C, which permit one person to clarify a bit of information such as the spelling of a name without wasting time thinking of words that might have a common reference in regard to the letter. So using the same system in a hospital setting, a researcher has implemented this in an operating room that would never be confused with the Echo Romeo for the emergency room. And reading back are also commonly used in aviation and other industries to prevent improperly received messages while transmitting information. So, in healthcare, as we have long used the readback procedures to verify the identity of a blood transfusion recipient, but remarkably, there is no traditional of the readback for other transfer of risky information that existed until the process was mandated by the Joint Commission in 2004. So it is one measure of our inattention to patient safety that until recently, the physicians would have been far more likely to hear the word, let me read that back to you, when calling, for example, for the local take care restaurant or any other nurses' stations of virtually hospitals. So, in one study, ReadBack has improved the transfer of critical clinical information during the simulated emergency situations. And the bottom line of this is that having a standardized process for the provider to provider sign out is essential as it can be prone to errors affecting the patient safety. So also sign out should take place in a standard place and at a standard time with other incoming and outgoing personnel that must overlap to the degree that is needed to transmit the relevant information. So ensuring that sign out occur in a quiet room free of distraction, it is critical and is ensuring that both parties have access to the hospital information system during the process of handoff. So increasingly the IPAS mnemonic, which is the illness severity, patient summary, action list, and situation awareness with the contingency of the plan synthesizing by the receiver, is being implemented in practical in the teaching hospital to standardize sign out. So several studies have shown that implementation of this system or checklist has improved the safety of the patients in the healthcare facilities. Also, on the USSF Medical Service, they insisted that shifts can change the handoff according face-to-face, while end of rotation handoff, such as when one hospital is signing out to another after about 1 to 2 weeks, which can take place by the telephone and with both parties that simultaneously review the electronic health record, sometimes via remote access to ensure the transmission of all information. So beyond those must-do's action, there are many variations on this same theme. As one study has showed that the use of a daily event reports, which is key overnight incident that automatically email to the daytime shift from the nighttime coverage, has reduced the duration of the sign out and also improved the quality of the handoff. So, in a pediatric ICU setting, the use of a daily goal sheet, which is a simple device to ensure that physicians, nurses, and patients can have a focus on the same limited set of goals. And a standardized bedside round has led to improvement in the communication with shorter ICU length of stay and decreased healthcare associated infection and also mortality. Also, a dry erase of a whiteboard in the patient room can promote communication and teamwork among all of the involved providers upon entering the patient room. And while all of these interventions seems intuitively sensible and relatively straightforward to implement, by now it is not a surprise to you that they are actually complex with changing that should be viewed through a human factor lens to ensure that they meet their purpose and doesn't create an unintended consequences negatively affecting the process of healthcare. Another important consideration when having a handoff of the patient is the site to site handoff with the rule of the system. So, this is an example of a patient who was 40 years old, mechanic that came to his local OR with chest pain and was admitted to the hospital to rule out the occurrence of myocardial infarction. The patient doctor ordered a chest X-ray in addition to the cardiac enzyme and serial of electrocardiogram testing. And since nobody expected this patient X-ray to show anything exciting, and since there was no checklist or even a protocol to remind anyone to check it, it was forgotten as soon as it was taken. After 12 hours, after all of the heart attack tests has proven negative, the patient was discharged, and the discharging hospital was unaware of the chest X-ray that and didn't think to follow up on the result and was totally forgotten about. And meanwhile, the radiologist had reviewed the X-ray and noticed a small lung nodules and filled a report to the patient record. And even though that a final discharge summary from the emergency visit was faxed to the patient's primary care physician office, it was lost and never read. So after 2 years, as the same patient developed a chronic cough and repeated a chest X-ray, this has revealed an obvious lung nodules. And the radiologist report has read that the nodule is markedly enlarged compared to the prior imaging. So that was the first time that the primary physician of the patient has heard of the breeder X-ray, and it was too late to do anything about it. And 18 months later, this patient died due to lung cancer because they didn't treat it earlier on. And according to a report in 2001, the crossing of the quality stamp has found that a new healthcare system for the 21st century, which is the Institute of Medicine, now called the National Academy of Medicine, compared the US healthcare delivery system to a railroad whose trackers change gag every few miles. So the healthcare is composed of a large set of interacting systems, including paramedic, emergency or ambulatory inpatient, and also home care. So as fourth, there are connected in losing the coupled but intrinsic network of individual teams, including procedures, regulations, and communication equipment with other devices. So these systems function within such diverse and diffuse management and accountably with information structure that the overall term of the health system is today to a misnomer. And historically, the major potential failure point in all of these interlocking systems was the piece of paper as the basic unit of the medical record keeping for centuries. So, moving papers across a healthcare transition is inherently risky as it can easily get lost, therefore, losing important patient documents and information. And unfortunately, even though that the vast majority of hospitals and substantial fractions of outpatient to provider are using electronic record system, the discharge summary and other records are often still printed and faxed to the provider practicing in other systems. Also, several people separated by place and function often need to see the patient data simultaneously, and each may can or even can create new data and observation that must be added to the record at the same time. And neither the paper or the disconnected electronic system can provide the ideal medium for a seamless care transition and information transfer. And many of these handoff techniques discussed earlier can help here as well, including the use of feedback, standard communication protocol, and the checklist, such as for hospital discharge, for the patient or the families and the provider. And regardless of that, part of the problem can be related to the absence of the integration in most of the American medicine and today medicine around the world. And taking, for example, the hospital discharge, which is an inherently risky transition period. For example, in the United States, the hospital discharging the patient and the physician receiving the patient are usually not part of the same organization. And in most cases, the physician is an independent practitioner. Therefore, the physician office information system, even if it is computerized, will rarely communicate effectively with the hospital system and vice versa. So, this is a setup of voltage drop in most of the critical care times as an important source for missing information. Also, integrated system of care in which the same organization owns or run the doctor office, the nursing home, and the hospital have great advantage in this regard. As the patient who leave a U.S. Veteran Affairs hospital for nursing home generally go to the VA-owned facility, which is the same true for the patient in the huge Kaiser permanent system that other large integrated delivery system should implement to improve the overall quality of the healthcare transfer or handoff process. So the reason that these handoffs generally go better in partial organization due to the partial informational owning system that is the same run in the private or the family physician office and the main hospital. So, organizationally, when a single system is responsible for care on both sides of a specialty or facility gap, they can collaborate on some smoothing the transition and bearing the consequences of any problems that occur. So, psychologically, the human beings simply communicate better with colleagues than with strangers. And this is the case for transfer or discharge to another hospital. So, from an informatics standpoint, large integrated systems tend to devote more resources to constructing, maintaining, and also improving the computerized linkage that is so critical to the optimal communication between the healthcare providers. Another example is that in the United States, there is considerable policy pressure designed to broaden the healthcare delivery system and also the physician to a higher level of integration to ensure effective handoff processes. In addition, the payment changes, such as bundles one with a single payment for an episode of care lasting for weeks, and also the promotion of an accountable care organization, which is a delivery system that includes the physician and the facilities. It is considered as a risk for its cost and the quality of outcome, which can receive bonus for the high value of care, which are their core effort to promote the integration of all steps or processes in the patient care. And whether they will succeed, this remains to be seen, but they are promising initiatives and current plans can call for them to grow over time. In addition, recognizing that most of the healthcare systems remain fragmented, much of the federal effort to computerize the healthcare system can be cost effective, but also having a higher cost that need to be focused on creating a set of standards and protocols to promote the interoperability even when computers are manufactured by different vendors. So the best analogy is the banking automatic teller machine, for example, ATM systems. In which example, the interoperability can allow the customer to make their transaction away from their own bank almost anywhere in the world without having to have human interaction. So recently, concerns have been raised about the patient privacy and the unauthorized use of medical information, and these concerns have taken an additional force with the prospect of the large interoperable computer systems that contain terabytes of sensitive patient data. So these concerns, partially addressed in the US by the Health Insurance Probability and Accountability Act, can pose a real barrier to the development of a national medical database or even to moving the patient information from clinic to hospital and back again. And while the abuses are possible, as there have been several high profile examples of them, the policymakers will have to weigh the desirability of the strict control over the patient data, which can sometimes mean that important information is not shared reliably and that tests are repeated unnecessarily. So, against the value of the linking of the healthcare system in an increasingly mobile society, which can affect the overall outcome of the patient care. And both individuals in this case and organizations have experimented with having the patient to carry their own data in the form of a smart card or even implementable chip as a way of addressing these privacy concerns. And because these systems seem to be unreliable or inflexible as one big challenge that it will need to be updated after every clinical encounter, the more realistic hope will be for a single set of national or even international standards that would combine seamless interoperability with a robust safeguard that ensure the reasonable degree of privacy. So, before turning to the issues surrounding the hospital discharge, it is worth re-emphasizing that every transition carries the potential for harm and are all worth scrutinizing for the risk of reduction opportunities. And for example, the transfers within the hospital itself from the emergency department to the floor or the floor to the ICU and also the OR to recovery room are all prone to errors, as the inter-hospital transfer is itself prone to multiple errors. In addition, a systematic review of the intra-hospital transition has identified a number of key themes and evidence that based on the improvement strategies. And one particular risk transition can occur when the patient leaves his or her hospital floor for a radiology study or procedure. And unlike the patient transferring to the ICU or another service where there are established nursing intake of protocol and formalized physician handoff, many of these inter-hospital transports are done hypertizely, with an upward decrease in the level of nursing care and monitoring capabilities, such as telemetry, and also the substantial ambiguity regarding what action to take in the event of deterioration. So one hospital can use a ticket to ride system where the ticket in which include the patient identification, their stability, and the risk information, including spheres as communication vehicles for the sending of the receiving personnel. And the transport personnel are also responsible for ensuring the nurse completes the ticket, which stays with the patient until returning to the home unit. And an analysis of over 12,000 transport has demonstrated improved transport documentation, higher patient satisfaction with the transport, and even fewer adverse events. with a well-designed checklist that may serve with the same function to ensure the proper transport within the hospital. And while the risk of intra-hospital transfer are obvious, it is also worth emphasizing that there are also major transition and handoff issues that occur in the community practice. So one study has explored the care coordination between hospitalists and the primary care provider around the hospitalization and found that at times the primary care provider didn't even know that their patients were hospitalized and often couldn't find important information in the discharge summary. So this problem is magnified by the sheer volume of information that an outpatient provider need to manage and digitalization that has not completely solved this problem. And in fact, there is evidence that computerization may even be contributing to information overload. So one study of three large outpatient practices in Texas found that primary care provider received a mean of about 70 electronic notifications per day compared to almost 30 notifications per day for the specialist. Also, the author has estimated that it would take the physician almost a minute to address each notification, likely in their own time, which adds more effort on the physician. While in another study, only two-thirds of the primary care physician has reported receiving consultation reports after referring the patient to the specialist, while over about 15% of the patients or the specialist reported that they sent such report always or most of the time. In addition to this, the providers who didn't receive a timely clinical information were more likely to report that their ability to provide high quality care was compromised by this issue. And even though the solution here would seem to rest with better information technology, this is proving harder than it looks. And in one study, the VA system has created an electronic alert for abnormal imaging results with alerts that went on both the receiving physician and also the radiologist. And despite what would appear to be a foolproof system, the flawed follow-up remains as a distressingly common issue. And similarly, computerized order entry has been held out as a savior for many errors in the transition and the medication reconciliation. Also, a researcher has examined about 40,000 computer-generated prescriptions and found that about 12% of the error rate has occurred. And clearly, our effort to solve the transition problems with information technology will need to be accompanied by equal effort to apply a human factor thinking. This is to be alerted for any unanticipated consequences and remains attuned to the challenges of trying to change the care pattern to a complex computerized system. So the issue surrounding one distinctive and risky handoff is the end of the year transition that occur when the resident graduate and turn their practice over to the new interns. Another important regard in the patient safety is preventing the readmission, which can occur with best practice for the hospital discharge. And as we have discussed, there is body of evidence that the hospital discharge transition is one we manage exceptionally poorly over the overall healthcare process. This was highlighted in the seminal study by a researcher that found that about 20% of the medical care patients are readmitted within a month of their discharge, and about one third return within 90 days after their discharge. Therefore, the author has estimated that the cost of the preventable readmission is about $17 billion yearly, which is a subsequent observational study that combined the physician survey and the chart review, which found that about one quarter of all readmission are preventable. Also, other studies have chronicled that literally of the additional post-charge disaster, and that nearly 20% of patients experience adverse events within 3 weeks of their discharge. Also, 40% of the patients are discharged with tests pending, and many of these balls are dropped and then affecting the patient outcome in general. In addition, 15% of the discharged patients have a discrepancy in their medication list. And astonishingly, a few discharge summaries reach the primary care physician by the time the patient returns for his or her first post discharge visit. And despite the powerful literature and that showed that relatively simple interventions such as post discharge phone calls or even the use of the transition coach can lead to striking improvement in the post discharge care and also decreasing the readmission rate in relatively few hospitals have implemented them. In addition to this, few hospitals that are not part of the integrated delivery system have become electronically linked to their referring physician office. And the policy changes that have promoted value based purchasing and the financial penalties for excessive readmission have turned improving the discharge of the transition into an imperative for hospitals with preliminary care doctors and their respective systems. And luckily, a number of best practices have been identified with proven beneficial effects on the readmission rate and other meaningful outcome for the patient's life. And in considering these best practices, several themes have emerged. The first is that hospitals will need to improve their discharge practices so that they can reliably have or get a meaningful discharge summary in the hands of the outpatient clinicians on the day of discharge, and also to ensure that patients receive a robust and understandable discharge instruction, not simply a check box or a form drawn from the Society of the Hospital Medicine Project. This can also help keeping in touch with the patient via a follow-up phone call or email or even video call while whatever it gets the job done, it must be implemented. Secondly, that high-risk patient would require something more as a post-discharge clinic visit, perhaps, or even a discharge or transition coach or a high-risk case manager. This isn't rocket science at all, as these interventions can make sense and have a manageable cost, which are challenging but also not impossible to implement. So they simply can take the institutional will, strong teamwork, and thoughtful integration of technology with appreciation of the principles of the quality improvement and also change management. And of all of these discharge transition program, perhaps the most creative has been the Project TRID, which is the re-engineered discharge. This was developed by a team at the University of Boston that's supported by the US government. So the Agency for the Healthcare Research and the Quality has read that the protocol involved giving the patient intensive pre-discharge counseling with customized discharge documentation, with early post-discharge phone call, and also rapid follow-up appointment to ensure the patient commitment to the discharge plan. So this intervention has resulted in 30% decrease in the readmission with modest cost saving. And one of the most expensive part of the intervention was the discharge counseling on an RN spent that nearly 90 minutes with each patient and family at a significant cost. So to address this issue, the Boston University investigators has developed an animated conversational characteristic that is called Louise. This program with the individual patient information, which she combined with the answer to the disease specific and general question. So, as this program had a pleasant looking female appearance, probably ambiguous race and ethnicity, appear on a computer screen that is wheeled to the patient bedside. This was speaking to the patient in a relatively fluent but unmistakable computer voice, as she can say, the doctor tells me that your primary condition is etc., etc., which is usually causes of a rapid heartbeat. So, do you have any questions the program would ask? Then the patient would answer the question by picking the choice of a touch screen interface. So, in a pilot study, this program has performed on an equivalent basis that was to the human discharge cost, which has resulted in saving about $150 per every encounter. So, more interestingly, not only did this most patient find Louise to be personal and responsive, but they also 3 out of 4 patients preferred interacting with her to receiving the discharge instruction from a live physician or a nurse. So, while this program can calmly walk the patient down to algorithm path, answer simply questions, and test basic understanding or dealing with complex situations, this can be showing empathy are not here for the forge. And nonetheless, this program success indicates that certain job functions that we currently allocate to humans can probably be accomplished by a thoughtful use of other staff technologies at a lower cost. In addition, with the rapid improvement in the artificial intelligence technologies, this program's success are likely to be even more human-like and creative. Combining technology with human skills and empathy will be needed if we are to meet the challenges of providing a high-quality, safe, reliable, and satisfaction care, which are at an affordable cost. So all the organizational needs structure and hierarchy can have the chaos, and it must have general large or organizational that have CEO and management with information that is to be transmitted. So this is not a bad thing, but taking the extreme with these hierarchies can be so rigid to the frontline workers, withholding critical information from the leaders or even revealing only the information they believe their leader want to hear. So this is a state that can easily spiral out of control, leaving the leaders without the information they need to improve the system, and the workers believing that their leaders are not listening, which are not open to discussions or opinions, which perhaps is not even interested in their important input. So, the psychological distance between a worker and a supervisor is sometimes called an authority gradient, and the overall steepness of this gradient is referred to as the hierarchy of an organization. Also, the healthcare has traditionally been characterized by steep hierarchies and very large authorities gradient, mostly between the physician and the rest of the staff, and errors like those in the wrong DNR cases in which the patient nurse suspected that something was terribly wrong but didn't feel comfortable raising her concern in face of incorrect group elimination that have alerted us to the safety of the consequences of this kind of hierarchies. We will be taking a break now for about 15 minutes and then we'll continue with discussing the role of teamwork in healthcare facilities. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So after discussing some of the issues that can affect the patient safety, an important point to consider is the role of teamwork in a healthcare facility affecting patient safety. So teamwork may have been less important in healthcare 50 years ago than it is today. So the pace was slower with the technology, less overwhelming with the medication that was less toxic and also less effective. And also the quality and safety appeared to be under the control of the physician, and everyone else played a supporting role in these issues. But the last half of the century have been brought a sea of changes in the provision of the medical care with massive increased complexity, think like liver transplant or electrophysiology, with huge number of new medication and procedures, with overwhelming evidence that the quality of teamwork often determine whether the patient receive appropriate care promptly and safety. For example, the outcome of trauma care can obstacle care or even the care of the patient with an acute myocardial infarction and the care of the immunocompromised patient are likely to hinge more on the quality of teamwork than the brilliance of the supervising physician. So, after recognizing the importance of teamwork to the safety and the quality of the healthcare, we should look at the field of aviation for some lessons that we can implement in the healthcare facilities. So, in the late 1970s and the early 80s, a cluster of deadly airplane crashes has occurred in which steep authority gradient appeared to be an important factor as those lower in the hierarchy were reluctant to rise or raise their concerns. So, probably the best known of these targeted was the 1977 collision of the Tenerife and the Canary Islands. So, while enthusiasm for teamwork training in the healthcare is warranted, it is important to appreciate the complexity of this undertaking and the limitation of the aviation analogs. So, changing the compete of the environment to prevent the next NRAP involves improving the teamwork between the two or three individuals who are the first officer, for example, or the flight engineering, who share similar training expertise, social status, income, and confidence. Where in a busy operation room, it may be the high school educated clerk or the young nursing assistant who harbor a crucial concern that need to be transmitted to the senior surgeon, who as likely as will not be trained in the era of the rigid hierarchy in the OR, what that was the norm. So those interested in improving the safety in the healthcare need to recognize the transformation in this culture, which is far more challenging than changing the culture of the cockpit. So an effective communication strategy for teamwork as per the data of the Joint Commission of the Essential that event program have demonstrated that communication problems are among the most common root causes for serious medical errors. So a well-functioning team can employ a number of strategies to improve the communication and teamwork. And the first set of strategies can focus on the way to dampen the authority gradient, as these efforts can include very simple techniques such as having the leader introduce him or herself by name, learn the names of the other workers, admit his or her limitation, and explicitly welcome the input from all of the members of the team. So these techniques shouldn't be limited to the procedural or the procedural poses of the medicine attending that might employ them on the first day of the ward rotation, but also as might an obstetrician begin on the shifting of the labor or the delivery floor. So, for example, a surgeon might introduce themselves as everyone else will be doing the same to all of the members of their operating room crew. And then they would say, you know, there will be times when I miss something or when I'm going to go in the wrong direction. So if I did, I would really need all of you to be my eyes and ears and notify me in such issues. So if you see anything that you are not comfortable with, or anything including things that I'm doing, I really want you to bring them up to me, which can be helpful in ensuring that the whole team work together with effective communication. So as a team, we can be far safer than any of us can be individually. So in the checklist manifesto, the surgeon and the safety expert has emphasized the role of the checklist in supporting such team behavior, in contrast to the traditional view of checklists as tools to simply promote the completion of a task. So there are also powerful opportunities to improve the team performance after a procedure or a clinical encounter is over. And knowing in the military and the aviation, as defibrillating, all the team member can take a moment at the end of the procedure and explicitly, in a blame-free way, discuss what went wrong and what went right and how to assess everything. So the lessons from these defibrillating are often invaluable. And just as importantly, the session can reinforce the value of team behaviors, which are critically important of speaking up, and the fact that everyone, even the leader, is considered to be having a risk of making a wrong decision. So, implementing standardized briefing and debriefing among the operation room of a regional medical center can lead to improved perception of the teamwork and communication among the provider. So it is one thing to tell a nurse or a clerk or even a medical student to speak up, and another to give them the tools to do so proactively. And many nurses can recall having tried to raise concerns with physicians only to be rebuffed and their uh, instruction or complaint was not taken into consideration. So while most nurses are likely to speak up when they believe the patient is at risk, one study found that about 12% of patients wouldn't do so even when they believed there was a high potential for patient harm. And to improve these odds and the quality of these exchanges, a number of techniques have been promoted, all designed to ensure that important messages are heard and acted upon. So, in most training programs, the focus of the CPAR training is on the nurses and from whom a tool was structured their communication with the physician to capture the latter attention and to generate the appropriate action depending on the service. So, there are data to suggest that this checklist can improve the nurse physician communication and overall outcome. And the need for the SPAR training has grown from the recognition that many nurses have been trained to report in stories, while the physicians have been taught to think and process information in bullet points. And an example for this is the traditional nursing assessment of the post operative patients with new chest pain that might be one of the following cases. As the patient is having some chest pain, he was walking around the floor earlier and he ate a good dinner. Then the nurse, for example, would say, I don't really know what is going on, but I'm getting an electrocardiogram as he was a little sweaty when he had his pain. But the patient was given rest with medication, including their insulin and antibiotics. So this patient had surgery earlier today and he is on a BCA pump right now. And after doing the SPAR training, the same nurse might call the physician and say, this is, for example, my name. I'm a nurse in the regarded unit, seeing your patient whose name is, in this case, Edward Chu, and will tell the physician the story of the chest pain that developed with the patient, which is the current situation. After giving a brief background about the patient condition and the assessment that was done by the nurse, then they would give the recommendation to ensure that the patient have the appropriate outcome. So another technique to improve the communication is the use of the CUS words. These involve escalating the level of concern, again, usually on the part of the nurse, but they would be equally applicable to many other workers, such as medical students, respiratory therapists, pharmacists, or anyone in the lower hierarchy who need to get attention of someone higher up. So, in an escalating order, it can begin with the use of the word I'm concerned about, then I'm uncomfortable with, and finally saying the issue. So, this is a safety issue, and it is important to teach those who might be receiving such message, usually the physician, to appreciate their meaning and respond appropriately. And those who use the CUS words to avoid overusing them and ensuring that they have the intended impact. And finally, the strong team can depend on members individually and collectively responding appropriately to crisis, in particular when the fog wave is set in. So the concept of a situational awareness can refer to the degree in which one perception of a situation matches with the reality. And failure to maintain the situational awareness during a crisis can result in various problems that compound this crisis. With the classic example that comes to mind, including certain airline crashes where the post crash investigation revealed that the crew was focused on retrieval flashing lights or gags, even as the plane ran out of fuel or crashed into the mountain. And as we see similar problems in healthcare facilities, such as during resuscitation, an individual or entire team can focus on a particular task, such as difficult central line insertion or administrating with particular medication, while neglecting to address immediate life threatening problems, such as respiratory failure or even pulse rhythm. So, in this context, maintaining a situational awareness might be seen as equivalent to keeping the big picture in mind, or even to cite one of the famous law of house God that included that a cardiac arrest patient is the first procedure to take your own pulses. Another major source for affecting the patient safety is the ventilator associated pneumonia. So, all of the HIIs and the VAP is the most deadly with an attributed mortality of about 10%. And about 10 to 20% of patients receiving mechanical ventilation, in particular for long periods, will develop VAV, which in turn can result in prolonged mechanical ventilation, longer hospital stays, and increased mortality. And many cases of the VAP can be prevented by strict adherence to several preventative strategies. And the first elevation of the head of the bed can seem to recumbent in at least 30-degree position, which is one trial resulted in about 18% decrease in the YAB cases occurrence. And the head of the bed elevation decreased the risk of microaspiration of gastrointestinal tract and upper respiratory tract secretions into the lung, which can serve as a nodus for infection. So, although that this intervention might seem like a relatively simple undertaking, experience has demonstrated that it can be a challenge, and usually because of the change in the patient position in general. Also, several tactics have been recommended to increase the adherence with about the elevation of the head of the bed, including enlisting the support of respiratory therapists and family members, placing a visual cues such as line on the wall to help identify whether the bed is in the correct position or not. Also, some modern ICU beds come with a built-in tool to provide continuous monitoring of the angle of the incline. And a second effective strategy is minimizing the sedation for the ventilated patient. Under one popular protocol is the patient sedative infusions that are stopped each day, allowing the patient to lighten to the point that they can answer simple questions. And this strategy, when coupled with a program of a systematic assessment, usually by a trained respiratory therapist, regarding the readiness of the weaning, results in shorter duration of mechanical ventilation and presumably lowering the risk of the VAB. In addition to this, several other strategies have been included in various VAB bundles, such as studies regarding the effectiveness of a regular antiseptic oral care that have reduced mixed results, with some demonstrating decreased VABs and others showing increased mortality rate. So the use of the endotracheal tubes with subglottic secretion drainage can work for patients expected to require mechanical ventilation for more than 48 or 72 hours. That is also recommended. And finally, while there is evidence to support the use of silver-coated endotracheal tubes to prevent the biofilm generation and ultimately the VAP, recent guidelines has generally doesn't recommend their use, citing insufficient data to support the decrease in the length of stay, also the duration of the mechanical ventilation, and the mortality rate. In addition to this, the VAB, like other HAS, has been considered for the inclusion in a variety of public reporting and payment policies. And one challenge is though that there is several VAB definitions which means that the determination of whether an individual patient has VAP may be subject to an interpretation of these results. And the broader topic of the hospital-acquired pneumonia will not be covered here or in any additional category of ventilator complication, as this group of complication is now referred to as a ventilator-associated event that will be discussed even with further details to ensure the proper implementation of intervention for these issues. With also the increasing popularity of this term owing to the CDC introducing of a new surveillance paradigm in 2013, as it used the objective criteria to identify 4 types of VAEs. These include the ventilator-associated condition, the infection-related ventilator-associated condition, and possible VABs and propagules of the VABs. So another possible source for complication regarding the patient safety is the central line associated bloodstream infections. So as the catheter access to the central circulation has become ubiquitous to provide long-term antibiotic, nutrition, and even vasoactive medication, as well as to permit the central blood sampling, so to have infectious complication of these lines. And the vast majority of these cases are associated with central venous catheter as the main source for complications. Also, patients in the ICU, nearly half of whom have CVCs, which are particularly vulnerable, while the past decade has witnessed a significant decline in the incidence of CLABSI from about 3 to even 1.6 infection for every 1,000 cases. Also, the estimation from 2009 has suggested that there were still approximately 23,000 CLABSIs among the hospitalized patients in the United States. And a meta-analysis has found that CLABSI led to nearly threefold increase in the odds of the inpatient death. In addition to this, the prevention of eclampsia has been of the greatest success stories in the patient safety movement. As analyzing the history of this success of the instructive as it is to build a series of small scales that then increasingly have ambitious interventions that blended the tools recommended to practice with the change and measurement strategies. And first, of course, came to the science that identifying the series of evidence-based practice that each reduced the incidence of the eclampsia and had even more powerful effect when bundled together with other strategies to improve the outcome. Also, a researcher has demonstrated that high rates of adherence to these practices led to a near zero rates of eclampsia in the ICU at the Johns Hopkins Hospital. And this was followed by the project that in which the widespread of implementation of this bundle of practice is more than 100 ICU in the Michigan, resulting in the breathtaking of about even 70% reduction in the eclampsia over 18 months, and a result of sustained over 18 additional months. An example of this is a recent 10-year analysis that demonstrated sustained reduction in about 120 ICU across 70 hospitals across the US, which has decreased in the mean rate of the eclampsia from 2 infections for every 1,000 catheter days to even 0.7 in 2013. And while the results of this Michigan have famously been attributed to the use of checklists which promoted the provider to adhere to the recommended practice, the Hopkins-based investigators and colleagues have taken pains to highlight the importance of the co-intervention that is aimed to improving teamwork, leadership, and culture. And an analysis of this study experience has led the British psychologist, which is a masterful guide for understanding the pathophysiology of the change in the complex organization. As this researcher has found that conceptual models and 6 microvolatiles for success factors has explained this implementation in Michigan study. And for anyone interested in promoting large-scale changes in a complex system, as well as the lessons from the subsequent studies and successful in the Match Michigan implementation state. So moving from the macro studies to the bedside, the Michigan investigator did a number of things right here as well. As the institutions have made major gains in hand hygiene, often empowering the nurse to question those entering the patient room about whether they have cleaned their hands, and the Michigan team encouraged this kind of culture for change. In addition to this, the use of the maximum sterile barrier precautions before any line insertion, which has been strongly associated with lower infection rate, was facilitated by the availability of a dedicated cart containing all of the necessary equipment to insert such an intervention. And importantly, even though that the removal of the central line at the earliest possible date is a key preventative strategy and should be encouraged by daily team discussion of the risk and the benefits of continued central access and routine line replacement, either by a new line at a fresh site or even by a line that was placed over the guide wire at the same site. This doesn't result in a fewer catheter related infection and was not part of the intervention. The Keystone Project is considered an important model for successfully implementing the patient safety practice on a broader scale, which is accompanied by rigorous measure of the effectiveness. Also, one of the key questions for the safety field going forward is whether the factors that led to this Michigan success can be replicated or in other venues under different circumstances and for other safety targets. We will be taking a break now for a Maghrib prayer, and then we will continue with the catheter associated urinary tract infection as a source affecting the patient safety.
Assalamu alaikum wa rahmatullah. Welcome back, everyone. Now, in discussing the most common sources of hazard for the patient is the catheter-associated urinary tract infections. So, urinary tract infections are the most common type of HAS, accounting for about 40% of the cases in the US alone. While the vast majority are associated with indwelling urinary catheters and the duration of the catheterization, which is the biggest risk factor for infection.
And even though that more common than the pulmonary embolisms and the CLABSIs, the catheter-associated urinary tract infection are less often fatal, and therefore have received less attention in the patient safety and infection control literature. But they have also received more notice in the past decade, in particular after they were included in the medical care no-pay list in 2008, and in 2012 became the subject of a joint commission of national patient safety goal. So the strategies for preventing the healthcare-associated UTI are similar to those used to prevent the central line infections. So specifically in patients who have indwelling catheter, maintaining a closed alarming systems and also using aseptic technique during the insertion and maintenance. Therefore, providing appropriate catheter care and removing the catheter as quickly as possible, which are all beneficial to the patient condition. So according to a researcher who have demonstrated that historically, nearly 1/3 of hospital doctors were unaware that their patients have even had a fluid catheter. Therefore, in a systematic review, this researcher has described the evidence supporting their use of the automatic stop orders and reminded to ensure that catheters are being removed when they are no longer needed. Also, studies regarding the use of both the silver alloy and the antibacterial coated urinary catheter have produced conflicting results, and they are not recommended for the routine use in general. While in men, a condom catheter are safer than the indwelling catheters. Also, in the last few years, significant progress has been made in the COTI prevention. While a study in 2016 has demonstrated that the implementation of a multi-component intervention in about 600 hospitals across 30 states achieved a marked success in decreased UTI catheter usage and also with the associated infection rate in a non-ICU patient. While in another article, the author has described in great detail the implementation efforts, including the multi-stakeholders, the collaborations that were associated with large national programs to reduce the catheter-associated UTIs. So an important approach that we can learn about for the patient safety is the approach to hospital-associated infection safety regarding the patient. So as a relatively nascent field, the patient safety has looked outside of healthcare to fields such as commercial aviation and clinical psychology, informatics, and engineering for many of its lessons and guiding practice, such as the examples that we have mentioned previously. However, the patient safety movement can also learn from the much older fields of infection control and hospital epidemiology. And former CDC director has made this important point in 2002 in the early years of the patient safety movement, which is that precise and valid definition of infection-related adverse event standardized method for detecting and reporting event with confidentiality protection, appropriate rate adjustment for institutional and case mix differences, and also evidence-based intervention program come to mind. And perhaps most important is the reliance on a skilled professional to promote an ongoing improvement in care, which has contributed to over 30-year track record of success in the infection prevention and control field. In addition to this, in an approaching patient safety, a standard definition should be used as much as possible when discussing the adverse events and preventability of healthcare organizations that should be encouraged to pool the data on adverse events in a central repository to permit the benchmarking in such data that should be appropriately adjusted and even reported. And finally, institutions should consider hiring a dedicated trained patient safety officer comparable to the infection control practitioners. Another important consideration in the patient safety field is that preventing venous thromboembolisms. So hospitalized or institutionalized patients often have conditions that place them at higher risk for venous thromboembolism, including inactivity, comorbid disease, and conditions that increase the risk of clotting, such as cancer, nephrotic syndrome, heart failure, or recent surgery, and also indwelling catheters. So moreover, because of the patient have limited cardiopulmonary reserve, a pulmonary embolism can be quite consequential and even fatal in these cases. While in fact, an autopsy studies have shown that among the patients dying in the hospital, BE remains among the most frequent misdiagnoses for most patients. While the risk of VTE in hospitalized patients is hard to determine with certainty because it can vary widely depending on the discrimination method, such as study showed that relying on clinical diagnosis has found a rate of about 20% for deep venous thrombosis and 1 to even 2% for BE after a major surgical procedure in the absence of prophylaxis. Also, rates after certain orthopedic procedures are even higher, where studies using more aggressive observational methods such as Doppler ultrasound on every postoperative patient have found a much higher rate. Also, it is not known how many of these asymptomatic clots would have caused a clinical problem, but surely some would have caused the problem indeed. And a detailed review of strategies to prevent VTE is beyond the scope of this. The interested reader is referred to the number of excellent reviews, in particular, the regularly updated guidelines published by the American College of Chest Physicians for a more updated review on the daily or more to-date review. Being in the patient safety focus with the system, Our emphasis will be on creating systems that ensure that every eligible patient will receive appropriate evidence-based prophylaxis. So given the complexity on the VET, a prophylaxis decision which varies by the patient group and clinical situation and can also change rapidly with the new research and pharmacological agents, as it seems unlikely that the physician education, the traditional approach, is the best strategy to ensure that the research is translated into practice. And rather, the emphasis should be on developing a standardized protocol through order sets and similar mechanism, which also, when possible, building these protocols into the clinical decision support system. And in fact, the ACCP guidelines strongly recommend that every hospital should develop a formal strategy that addresses the prevention of VTE. Where in a study of 2,500 hospitalized patients, half the patients received a standard care, while the other half, physicians, received a computerized notice of their patient risk of thromboembolism. In the second group, it was required to acknowledge the notice and explicitity of choosing to withhold the prophylaxis or order it, which was graduated compression of stocking, pneumatic boots, and unfractioned or even low molecular weight heparin or warfarin. So the physicians that were receiving the alerts were far more likely to order appropriate prophylaxis, and the rates of the clinically diagnosis for deep venous thrombosis or BE fell by 41% in their patients. Where in another study of two ICUs based report on the adoption of a series of tools that promoted team communication, promoted clinician with evidence-based recommendation for ICU prophylaxis, and even gave a clinical real-time feedback on their performance. In both of these studies, they found significant improvement in the use of evidence-based prophylaxis intake. While in a more recent study, they concluded that while many interventions are effective in preventing VT to varying degrees, the active tools such as computerized VTE prophylaxis alerts are more likely to succeed than the passive ones. And of course, for alerts to work well, they must be thoughtfully integrated into the provider workflow without having additional impact on their usual or daily tasks. Also, another analysis found that many patients who were diagnosed with VTE while hospitalized had been prescribed prophylaxis appropriately but didn't receive the whole dose. And this study has highlighted that the importance of measuring what matters in this case, which is the actual receiving of the prophylaxis rather than just the prescription. So, as with many patient safety targets, moving from local improvement strategy to a national reporting and payment changes can involve some complexity. So many national programs can determine the presence of VTE based on the hospital administration records largely that were creating for the billing purposes. While several studies have shown that such data can lack the specificity for the hospital-acquired VTE, because either of the thrombosis that was present on the admission or the coding that was inaccurate. In addition, that diagnosis may be subject to significant surveillance bias. While in addition to the accuracy of coding, the issue of preventable arises from the hospital, which are no longer reimbursed for certain cases of VTE. While in one study, almost 50% of the hospitalized patients found to have VTE received what is considered to be optimal prophylaxis, suggesting that not all VTE are preventable adverse events. So this is of greater concern now that the diagnosis of VTE can carry a financial implication for the hospital, where a study in 2014, the Center of the Medical Care and the Medical Aid Services began using the AHRQ patient safety for selected indicator in both the hospital acquired condition reduction program and the hospital value-based purchasing program. These programs in which the hospital performed poorly on a metric are financially penalized, therefore improving the overall income or outcome depending on the penalization. So one component of this program is the measure for the post-operative PE or the deep vein thrombosis. This has been heavily criticized for surveillance bias that was associated with some of its component measures, including the post-operative VE, for the inadequate risk adjustment, and also for the challenges that were associated with accurate identification of adverse events. So, a researcher has argued that the reimbursement strategy in which the presence of the adverse event of VTE in this case would lead to a chart review to determine whether the evidence-based process were carried out or not, and the reimbursement would be withheld only if they were not. معلش حصلت مشكلة في النت. طيب as we were saying, so in regard to venous thrombosis, as the hospitalized or the institutionalized patient often have conditions that place them at a high risk for VTE, including their inactivity and also the comorbid disease and conditions which increase the risk of clotting, such as cancer, nephrotic syndrome, or heart failure, or even having recent surgeries. So moreover, because such patients often have limited cardiopulmonary reserve, a pulmonary embolism can be quite consequential and even fatal in most of the cases. And in fact, an autopsy studies has shown that among the patients who were dying in hospitals, BE remained among the most frequent misdiagnoses for those patients. And the risk of VTE in a hospitalized patient is hard to determine with certainty, that is, because it can vary widely depending, of course, on the discriminate method, as studies relying on the clinical diagnosis has found a rate of 20% for deep venous thrombosis and about 2% for BE after having a major surgical procedure in the absence of prophylaxis. Also, rates after certain orthopedic procedures are even higher, where studies using a more aggressive observational method, such as the Doppler ultrasound on every post-operative patient, have found a much higher rate. So it is not known how many of these asymptomatic clots would have caused clinical problems, but surely some of them would have caused even fatal complications. Moreover, a detailed review of the strategies to prevent VTE is beyond the scope of this, with the interest of the reader that is referred to a number of excellent reviews, in particular, the regularly updated guidelines by the American College of Chest Physicians. And in keeping with the patient safety focus on the system, our emphasis will be on creating systems which ensure that every eligible patient receive an appropriate evidence-based prophylaxis. And given the complexity of VTE prophylaxis, the decision, which can vary by patient group and the clinical situation, and can also change rapidly when there is new research and pharmacological agent, that it seems unlikely the physician's education and also the traditional approach that is the best strategy to ensure the research is translated into practice. Rather than that, the emphasis should be on developing a standardized protocol through the order sets and also similar mechanisms when possible, building these protocols into the clinical decision support system. And in fact, the ACCP guidelines can strongly recommend that every hospital develop their own formal strategy that address the prevention of VTE. Whereas in a study of about 2,000 hospitalized patients, half of the patients received a standard care, while the other half of physicians has received a computerized notice of their patient risk for thromboembolism. In the second group, they required to acknowledge the notice and then to explicitly choose to withhold the prophylaxis or order it through a graduate compassion or even any type of medication. The physicians who were receiving the alerts were far more likely to order appropriate prophylaxis and the rate for the clinically diagnosed deep venous thrombosis, or even BE, has fell below 40% of their patients. In addition to this, two ICU-based studies has reported on the adoption of a case series of tools which promoted team communication and promoted the clinical with the evidence-based recommendation for ICU prophylaxis, and also gave the clinical real-time feedback on their performance. In both of these studies, they found significant improvement in the use of evidence-based prophylaxis. Where in a recent review, they concluded that while many interventions are effective in preventing VTE, in varying degrees, the active tools such as a computerized VTE prophylaxis alert are more likely to succeed than the passive ones. And of course, for the alerts that to work well, they must be thoughtfully integrated into the provider workflow to prevent any overworking of the physician. While another analysis found that many patients who were diagnosed with VDE while they were hospitalized had been prescribed prophylaxis appropriately but didn't receive all of the dose. So, this study highlighted the importance of measuring what matters in such cases, which is the actual receiving of the prophylaxis rather than just the prescription. And as is the case with many patient safety targets, moving from a local improvement strategy to a national reporting system and payment can change the involved in some complexity. So many national programs determine the presence of VTE based on hospital administrative and records, which are largely created for the billing purposes. And several studies have shown that such data can lack the specificity for the hospital-acquired VTE because either the thrombosis was present on the admission or the coding was inaccurate and the diagnosis of VTE may be just subject to significant surveillance bias. While in addition to the accuracy of the coding, the issue of the preventable arises when the hospital are no longer reimbursed for their certain cases of VTE. Where in one study, almost 50% of the hospitalized patients found to have VTE also received what is considered to be an optimal prophylaxis, therefore suggesting that not all VTE are preventable adverse events. So this is considered of a greater concern now that the diagnosis of VTE carry a financial implication for the hospitals. Where in 2014, the Center for the Medical Care and the Medical Services began using HRQ, the patient safety, for selected indicators in both the hospital-acquired condition and the reduction program for the hospital value-based purchasing. So both of these programs in which the hospitals that perform poorly on a metric are financially penalized for their actions. So one component of this program is the measure for the postoperative VE or the deep vein thrombosis. In the first one, it has been heavily criticized for the surveillance bias that was associated with some of its component measures, including the postoperative VE for inadequate risk adjustment and the challenges that were associated with accurate identification of the adverse events. And the researchers have found or argued that the reimbursement strategies in which the presence of the adverse event of VE associated infection led to a chart review to determine whether the evidence based process were carried out correctly or the reimbursement would be withheld only if they were not. And even though that unwidely and inexpensive, such strategies would seem to have failure than the penalized hospital when they did everything even right. And a similar argument, of course, can be made for the other events in the medical care of the no base that is listed, which are only partially preventable. And of course, one must keep in mind that some of the adverse events can initially be thought to be unavoidable, such as central line associated bloodstream infection, where later on they are proven to be completely preventable through the implementation of appropriate intervention strategy, which is unlikely to be the case for VTE. Another very common and important consideration in the patient safety field is the prevention of brittle ulcer. So, brittle ulcers are defined as a damage to the skin of the underlying structure that is caused by unrelieved pressure, causing therefore pain, delaying in functional recovery, and also predispose the patient to local and systematic infections. And it is estimated that about 1 in every 7 hospitalized patients in the US alone has or will develop a pressure ulcer, which corresponds to 2.5 million patients that are treated for pressure ulcer yearly, which is more than 60,000 patients dying each year from its complication, and that the incidence of pressure ulcer is also increasing. In addition to this, similar to the patient falls as seen in the preventive falls that we'll be discussing later, the first step in the preventing pressure ulcer is to identify patients who are considered at risk with a validated risk assessment tool. So a variety of such tools are available, and in most of them, they assess the nutritional status, the mobility, and the inconsistency of the patient with their sensory deficiencies. So in the United States, the most commonly used tool is the Barden scale, which is to be assessed on admission to the hospital or even with a skilled nurse facility. So the subsequent daily in the case of the hospitalized patient can be assessed with the goal of the risk assessment are both the overall prevention and the prevention in the early stage of the pressure ulcer from becoming a more severe stage 3 ulcer and even 4 with deep tissue injury. So these risk assessments are followed on by a variety of preventative activity focusing primarily on the risk of the patient, which the Institute of Healthcare Improvement Bundle include the following strategies to be implemented and improving the patient safety. So a daily inspection of skin is recommended from head to toe with a special focus on the high-risk locations such as the sacrum, the buttocks, and the heels. Also keeping in mind that the patient who are dry while treating overly dry skin with moisture to prevent them from occurring of cracks. Also optimizing their nutritional and hydrational intake and regarding to specifically their protein intake to prevent the development of protein deficiency, therefore developing pressure ulcer. And also minimizing the pressure through frequent repositioning and the use of pressure relieving services such as special bed for patients who are considered to be at a higher risk. So up to date, there is no large-scale methodological, strong clinical trials that has defined the evidence-based best practice or the degree to which the pressure ulcer are truly considered as preventable cases. And the systematic review suggests that the implementation of a multi-component intervention is the best method which are appropriate for the preventional strategies. Another consideration in the patient safety field is the prevention of falls. So these are common yearly. More than about 1/3 of the community dwelling elders fall and are frequently having morbid falls that will lead to severe complication or health impact on their health. So as older patients are hospitalized or even institutionalized, they are placed on multi-medications and often immobilized. With having the risk of fall grows, with even a fall rate of the acute care hospital ranging from 1 to 9 per every 1,000 days in the hospital. So when hospitalized patients do fall, about 30% of them to even 50% of the falls can result in severe injuries, and a substantial fraction of these injuries are serious. And interestingly, when asked about what they feared during hospitalization, adult patients rate falling and getting hurt as the greater concern than being misdiagnosed, which is having the wrong test or procedure done. Therefore, patients who suffer from serious falls-related injury while hospitalized can cost about 14,000 more and even stay 7 days longer than the age and disease-matched control. So this cost can include not only hospital stay, but also the cost of the rehabilitation or any other liability payment. In addition to this, all institutionalized patients should formally be assessed for their fall risk in a manner that incorporates both the clinical judgment, that is usually during the nurse admission assessment, and also results from a validated screening tool. It is also important to note that multiple studies have produced conflicting results as to which screening tool is considered the best to be implemented in those patients. In addition to this, a systematic review and a meta-analysis examined about 51 distinctive evaluations for their fall risk screening tool and found that while the Morse fall scale of the CT Thomas risk assessment tool in the failing elderly inpatient tool may be useful in some of the cases, but it is not clear that either is better than the nurse clinical judgment. In addition to this, to the patient-centered risk factor that is captured in these tools, the environmental factors such as the room or the lack of a clear path to the door and bathroom, or having the necessary items beyond the patient reach, with extrinsic other environmental factors such as polypharmacy can all be considered as risk factors that need to be considered. And as a systematic review found that the best predictor for the future fall were the history of falls in the past year and also the presence of an active gait or a balance problem. In particular, in the patients who were found to be at risk for falls, those who have active prevention efforts that should be instituted for them immediately upon entering the hospital. And even though that the use of the restraints such as a fist or a bed rails or wrist restrainer might appear to be a fall prevention strategy, evidence suggests that the opposite is correct. And for this reason specifically, as well as for the ethical background, the restraints should only be used as a fall prevention strategy, only as the last solution. And other important strategies can include early mobilization and effort to preserve the patient's strength in general. In addition to this, using a hip protector to prevent the hip fracture in the high risk patient who do falls has shown to be of benefit in some of the studies, but others can use their remaining controversial. While a number of other commercial practices have also not been conceivably demonstrated to help, including the use of a bed alarm to a single patient, which is regardless of the use of a specially padded floor, which can appear to decrease the harm from the falls, but may also increase the fall risk from tripping. In addition to this, the camera monitoring is sometimes used for patients who deem to be at a high risk for fall. And one study has found that the use of a webcam and a virtual bed rail alarm was associated with even fewer patient falls. While in some hospitals, a staff member, sometimes referred to as a sitter, may be individually assigned to watch the patient at an increased risk for fall, but this intervention is sometimes regarded as expensive. While a recent review of the literature on the sitter can suggest that their effectiveness in reducing the falls is mixed at best. And there is some data to suggest that the centralized video monitoring of the patient room are outfitted with the camera and individual monitoring with multiple patients simultaneously from a centralized location where alerting the bedside nurse if the patient is demonstrating any concerned behavior, which may be effective to preventing falls and also the costless than one-to-one observation. So, in order to prevent the inpatient falls, the hospital should develop and implement a program that consists of three general components. The first is screening for patient risk, two, creating an individualized fall prevention plan for the patients who are considered at risk, and implementing the individualized plan along with the universal fall precautions for all patients. In addition to this, two rigorous studies have demonstrated that fall prevention strategies truly work, where in one study at the two Australian hospitals, the patient received a comprehensive education program which included both a written and a video-based material with follow-up physical therapists. So the falls were reduced by approximately 50% among the cognitively intact patients, and importantly, simply providing the educational material without any physical therapy follow-up carried no benefit. So in the second study, they tested the value of a fall prevention toolkit in 4 teaching hospitals. The toolkit, which was implemented through a sophisticated hospital information technology system, included a risk assessment tailored for prevention intervention that is aimed at both the patient and the different providers, and also tailored for the educational intervention. So the results were impressive as falls in older patients were reduced by about half. And the study was not sufficiently powered to detect any change in the fall-related injuries. And together, the use of study can suggest that fall rates can be cut through thoughtful implementation of programs that include risk assessment, comprehensive multidisciplinary prevention strategy, and patient education combined with using information technology. And while these successes can suggest that some falls are preventable, it is important to know that the evidence around fall prevention remains controversial. In addition to this, a 2016 cluster of randomized controlled trial across 6 Australian hospitals examined the impact of a bundled intervention on the rate of falls on an adult patients who were found no differences in the fall rate between the control and the intervention group, even though that the bundle was successfully implemented. We will be taking a break now for Salat al-Isha, and then we will continue discussing the risk of the patient safety. Assalamu alaikum wa rahmatullah. Welcome back, everyone. We will continue with discussing one of the major issues affecting the patient safety, which is the ambulatory safety for patient transport. So, the implication of these ambulatory versus hospital differences are important as we turn our attention to the outpatient safety. And as most clinics will be able to identify areas in which the adverse events are common and target their efforts accordingly, these are likely to include improving the medication prescription, testing the results, follow-up, and communication with referring the physicians and hospital providers, with also the patient's engagement and education. And in a far-reaching discussion of a delayed diagnosis for a renal mass, the safety expert has highlighted some of the number of the Swiss cheese model that relate problems, along with many opportunities for improvement in the ambulatory test follow-up services. And while the advent of a computerized provider order can carry the potential to decrease the outpatient prescribing error, and also the growing adaptation of IT systems has the potential to improve the safety of the ambulatory medicine more generally, which is a robust electronic backbone that is only one component of a safer system for the patient impact. And indeed, in a recent study of the EHR related malpractice claims, in which most of the cases came from the ambulatory setting, they concluded that the unintended consequences of the healthcare IT are real and are associated with adverse events that can cause a significant harm. And as with IT, in all healthcare settings, it is relatively easy, natural, even to think of IT as the holy grail. If we just had a good IT system, then it will be common to refrain from most of the errors that can develop in a health system. Also, there is no question that the need for such system exists, just considering these sobering statistics, which are in a typical week, the average primary care physician is responsible for following up on 18 chemistry hematology tests with 40 radiographs and about 12 pathology specimens, where a recent survey study can suggest that follow-up test results remain as a major concern for the primary care providers. In addition to this, fewer than half of the primary care physicians are satisfied with their system for managing test results, and more than 4 in every 5 report having had at least one test result as they wished they had known about the earlier in the prior 2-month period. And more often than not, some of the crucial pieces of information, such as laboratory and radiology tests, consultant pathology reports, procedure notes, and more, is missing the primary care visits, where another study had showed that 1/4 of the time, unfortunately, early evidence from the ambulatory IT implementation demonstrate that IT is not implemented in all of the settings, where in addition to this, a primary care group nearly broke up over the challenge that accompanied the implementing of a new system, which is after the dust settled, none of the physicians could imagine going back to paper, even though. And a more sobering, several recent studies has found that persistently high rates of error in both the medication and the radiology information flow, even after IT implementation, were an early evidence that the presence of an ambulatory health record was even associated with improved quality that was limited in some of the cases. And at the same time, it is inconceivable that we can achieve a highly reliable ambulatory care without effective IT. And these sobering results can illustrate, as always, that building and implementing IT is harder than it looks, which systems that need to evolve based on the provider and patient feedback, with also human factors that need to be considered in the development and also the implementation of the system. And addressing these challenges is increasingly crucial as adoption of the ambulatory setting has grown rapidly over the last decade. And according to data from the Office of the National Coordinator for Health Information Technology, about 80% of outpatient physicians had implemented some types of EHR by 2014, and about twice as many as in 2008. And while the flaws of the healthcare IT continues to be well recognized, findings from a 2015 national survey of primary care providers suggest that the physician can recognize the potential for health IT to even improve the quality and safety, with about 50% of the physicians and 60% of nurses practitioners and the physician assistant responding to that implementation, which has had a favorable impact. So, in addition, more recent studies have shown a positive impact of the health IT adaptation on the ambulatory care. And in addition to this, as healthcare IT adoption continues to grow rapidly, some of the communicational steps that can be taken into improving the ambulatory medication safety are even worth reviewing. While the role of the patient is crucial in the ambulatory safety, in particular since the patients spend so little time with their providers and far more time at home managing their own health. So the strong emphasis should be placed on the patient education by using proven methods such as the teach back method and the empowerment with a particular attention that is paid to the issues of the health literacy and the cultural differences. And overall, improving the safety in the ambulatory setting will not necessarily be harder or even easier than in the hospital, where we just justify the answer. And as with much of the patient safety field, which is often involving the extrapolating of the experience from other settings, such as the crew resources management, which worked so well in the commercial aviation, and working in the labor and delivery suits, which can all be important to remain sensitive to the differences in the structure and the culture of such setting as we try to translate what we know about the safety from the hospital to the office setting. And as with much of the patient safety field, which often work involving the explorating service, moving forward, the expert can suggest that the research in the ambulatory safety should focus on several areas. These can include broadening the data on the epidemiology of ambulatory safety, focusing on the areas which are tangible improvement to prevent harm which can be made, and also improving the patient and the family engagement around the safety in the outpatient care, and also trying the ambulatory safety to the high profile issues like the care transition, with also paying attention to the readmission and improving the infrastructure around the ambulatory research. And while the ambulatory safety was all but ignored during the first few years, the safety movement research funders, accreditors, regulators, and specialty societies have become to appreciate its importance as having the patient and their advocates. And all of these stakeholders are now exerting their influence. So the next decade is likely to see a far more activity in the ambulatory safety arena and far more pressure to improve. Another major source for error in the patient safety is the information related problems. So the provision of healthcare is remarkably information intensive, and a large integrated healthcare system process of tens of millions of information exchange per day, even though with multiple pathways, including electronic health record as well as via beepers or text message or even emails, can present a source for error. But even with the high volume that is just beginning, considering the task of tracking every single patient, current disease, past medical history, medication intake, allergy, test results with other risk factor, with even the personal preference such as cardiopulmonary resuscitation, all can be a source for error. So even though that now we do have over months or even years, then adding the fact that the patient is seen by many different providers, this is scattered across regions, often using different medical record systems that are generally doesn't communicate with one another. And even taking the payment decision, the insurance need accessing some of the information to thus the source of the insurance, which in the US, for example, is often the patient employer. And because of the privacy concern, both should receive only essential information to tell them of the patient HIV status or even their psychiatric history that would be highly inappropriate, damaging, and possibly illegal. And even to make it harder, assuming that the patient is in a car accident and taken to the ER, then the nearby state where the patient is stabilized and admitted to the hospital. So ideally, the doctor and the nurses would see the relevant clinical details of her medical history and preferably in a format that highlighting the information they need without overwhelming them with any extraneous data. Also, orders must be processed instantly with none of those systems that is down for planning maintenance or even orders that are processed on the next business day so they can be familiar with the commercial transaction. And during the patient hospital stay, not only would there be seamless links among all of the new observations, such as neurosurgeon Lee can easily view the ER doctor notes. Also, the resident can quickly find the patient's vital signs and laboratory studies, but also the various components that would wave together seamlessly, such as, for example, the system that would promote the doctor with the information regarding appropriate therapy or even tests for a given condition, along with links to the evidence supporting any recommendation. So the system would warn the nurse that the patient is allergic to certain medication before administering it, and the system would tell the doctor or the pharmacist which medication are on the formulary and steer them to the preferred one. And meanwhile, the vast trove of data being created through this patient case and millions of other like it would be chronicled and analyzed, searching for the new patterns and the disease evidence of the preferred strategies and even more. In addition, all of this would be iterative as new information can emerge uh, of the research about the disease risk factor or the best even practice that it would be seamless flow into the system, spurring the next patient care to be even better. Also, contrast to this vision of information with the prevailing state of most doctor office and hospitals, even though that the policies have spurred rapid digitalization of the health information in recent years, of reaching up to 90% of outpatient physicians and over about of the non-policies of the acute hospital care setting in the US that were recording using the electronic healthcare system. Notes are often entered as free text, not in the format that the facilitating the analysis or the productive interaction with other pieces of the system data. And when the patient moves across the soils from the outpatient to the inpatient, or from state to state, from hospital to hospital, there are crucial information that rarely move with the patient, even though that the work is ongoing to change with this. Also, communication of facts such as medication list, allergy, or past medical history, which should be streamed through the system instead, that is at the mercy of the person to person interaction, or even have a prized pinball game of the photocopies bouncing from one place to another. And even at the level of the individual practitioner, the impact of this data chaos is profoundly demoralizing or even wasteful, and most importantly, dangerous. And even just watching a nurse take the patient vital sign on a typical hospital ward, as these nurses looking at the numbers on the screen, for example, of the pressure cuff, and even in a digitally advanced hospital, so often as the nurse record them on an index card or sometimes on a paper or her arm even, that is hopefully to the correct patient name to be entered afterward. So after the nurse returning to the station and typing these numbers again, hopefully the right numbers or to the right patient into the appropriate place in the chart, or hopefully even the appropriate chart. So all of these steps can be a source for error. So in a teaching hospital, an intern can transcribe these vital signs into another card during their morning round, and they present these data into their residents or even later to their attending who teach them the same thing. And eventually, each of these practitioners will write or dictate the separate notes for the medical record. So there is a lot of information that we will recall or even in the digital form that is frequently wrong, or that a busy healthcare professional find that huge chunk of their valuable time are sequestered by such information, or even that the patient has a sense practically that they are asked the same question by 10 different people and that the right hand has no idea what is a left hand is doing. And why has the healthcare in the most information intensive of the industries entered our remarkable age of computers so suddenly and reluctantly? So, part of this reason is that until recently, business or clinical cases of healthcare information technology was far from ironclad. So, such justification was needed because the HIT is extraordinarily expensive, affecting a lot of the healthcare systems, with some cases for even large multi hospitals health systems. So these can be extremely challenging to implement with having or requiring a higher degree of accuracy. Also, healthcare computer systems have traditionally been relatively clunky and the user unfriendly, which is in part because of the market for them that was too weak to fund with vigorous research and development. Also, and the generation of the user feedback and reinforcement of the cycle that is needed for the complex system to mature. And in regard to the patient safety movement that has catalyzed the widespread recognition with robust digital scaffolding, that is absolutely essential to efforts to improving the quality, safety, efficiency, and coordination of care. And there is a striking example of success, such as that enjoyed by the huge veteran affairs system, whose early adaptation to EHR are computerized provider order entry that sparked a substantially improvement of the quality of care. In addition, large and convincing literature demonstrated that a well-designed, implemented electronic system can lead to significant benefit for the system and for the patients. And yet there is more troubling, even though that's the entirely surprising side of the story. As over a decade ago, the safety expert has expressed concerns that the early glowing evidence about the HIT benefit had come from a handful of institutions that lovingly built their own system and possessed highly committed leaders and invested heavily in computerization. As a researcher has indicated that average hospitals will not share these conditions any more than the local surveillance troop that resemble the metropolitan effects. And more than the one CIO that tried to airlift the commercial system into their hospital, then stood scratching their own head of the system that seemed to be very simple to implement but had poorly performing capability in real life. So, as you have already seen, our suspicion that is it is not implementable of the commercial IT systems at the thousands of hospitals or even hundreds of thousands of the ambulatory office that may not go so quite smoothly, even though with proving correctly, even if it was practiced immediately. So, a growing literature tells stories of HIT implementation failure that were unanticipated consequences and had even harm when they were tested. And indeed, for most cases, this was describing the serious medication of error that occurred at our own hospitals in an error that vividly illustrate how the unintended consequences of the HIT implementation can lead to significant harm. In addition, for example, of this is the 16-year-old boy who had chronic genetic immunodeficiency and was supposed to receive one antibiotic tablet twice a day, but instead was given about half of the dose each time. So the overdose, which led to a near fatal grand mal seizure, stemmed from the combination of poorly designed user interface, alert fatigue, undue trust in the technology, and also failure to speak up. And this case is sobering but also useful tale that one highlighted the immense challenges of fundamental change in the complex adaptive system with critical need to use human factor designing principles that are overwhelming with complexity and underlying tasks that might initially seem like a routine task or even ordering or administrating the medication. This has all tremendous impact that the error can have on both the patient as well as on the provider or nurse who care for them. It is also a classic illustration of the Swiss cheese model of error that we have explained yesterday. So, in a well described, the main type of HIT system, some of their safety advantages and some of the problems, including new kind of error they can create. Also, because the HIT addresses so many safety targets and is component of so many solutions, considerable information about it or its role in the specific area can also be found through their implemented book. So the electronic health record can, because of the most of the medical error, represent failure in communication and the data transmission. The computerization of the medical record would seem like a safety interpretation. So while the old term was electronic medical record, today the term electronic health record replaces it and is generally preferred, since it is emphasizing on the role of the patient in viewing and even contributing to the record, and the fact that the EHR may chronicle and even influence the health status, not just the patient medication and diagnosis. But also to realizing their benefit, attention must be paid to a variety of system and user factors that can also impact their use. So the safety factors can include the ease of use, the speed with which the data can be entered and retrieved, and also the quality of the user interface, and the presence of the value added feature such as order entry, decision support, sign out, and the scheduling system. Linked to all of these necessary data, such as imaging and automatic report, can be included. So user factors can primarily relate to the training and readiness of the provider and the non-provider workplace, and both systems and user factor can play a role in the case of the Citra overdose described above. And the user efficiency is practically important, despite the hope that the computerization would save time for the provider. Evidence indicates that the opposite is often true, in particular for the physicians. Also, many doctors can now complain that they have become glorified data entry clerks while also struggling to manage an overbalance of the data and a large volume of electronic communication with both the patient and other providers. And all of this has been associated with a troubling increase in the rates of physician burnout. So some of this cost in time may be repaid in more efficient information retrieval, but increasing attention will need to be forced on the workflow of the hours. And we should also remember that digital blood pressure reading in the wired hospital that will magically leap from the blood pressure machine into the EHR, where it can be seamlessly imported into each provider node and then trigger a useful decision support. So effective system will of course provide use efficiency benefit for the administration, the researchers, and the insurers by capturing the data in a standardized format and allowing for the electronic transmission. But unfortunately, this can facilitate the movement of bits and bytes that has a dark side in the form of a copy and the paste phenomenon. And one tangent-seek assist that captured the problem beautifully has said that the copy and paste command allow one day note to be copied and used as a template for the next day note. And ideally, the old information and diagnostic impressions are deleted with the new ones being added. And in reality, however, there is no deletion, only addition. And daily progress note can become progressively longer and contain sensing information while admitting that diagnostic impression are long since the discharge is audibly noted by the date after date. So, for example, last month's echocardiogram report can take up permanent residence in the daily results section, and complicated patients are on the post-op day for 2 weeks. And one can wonder how the utilization of review can interpret such a statement. So, a cohort study has performed in the ICU of an academic medical center found that copying and pasting of the note to be preventable among both the trainees and the attendings. While in fact, almost about 75% of the notes examined more than one-fifth of the content of the daily progress note that was copied from the prior day note. And some of the IT system can disable the copy and paste function, even though that this may be unacceptable to provider. Some information really need to be a statistic from one day to another, and having to retype or redictate, it's a wasteful and annoying for most of the cases, with resourceful provider that can usually find a way to bypass such restrictions. While in the end, copy and paste can resemble many elements of the patient safety, in that introducing the structural changes without ensuring the caregiver possesses the required education and professionalism is likely to lead to a new type of mischief or even harm to the patient. Also, one important choice of the EHI developers is the use of a structured versus unstructured data. And physicians in particular have always preferred entering data as unstructured rows, which are captured through typing, which has also the advantage of easing of the use and familiarity, which is consistent with the long tradition of telling a patient story. While on the other hand, unstructured data are difficult to analyze for patterns and to use to support the quality improvement and the public reporting activity, with also linking the computerized decision support systems. Or even structure or coded data that are captured via templates and automatically fed into the EHR after being recorded by electronic devices can support these functions, but they can also clash with the clinician's mental model for the data acquisition and analysis. And ongoing research is attempting to identify the best mix of structured and unstructured EHR input, and also to develop new ways through computerized natural language processing to even main narrative prose for the key data element. Also, one study performed in the Veteran Affairs Health System demonstrated that natural language processing of the algorithm could actually or accurately identify the post-operative complication by screening the provider note. And this finding is supported by additional research that is likely that the advance in the EHR in the future will combine the best of both types of data captured and analysis, thereby decreasing the today documentation and information retrieval burden. In addition to this, another important advance in the EHR is the ability to promote the patient engagement, and at the very least, allowing the patient to access their own laboratory data and even giving them the ability to schedule their own appointment can represent a real progress in the healthcare process. And as of this writing, some about 10 million patients in the US have full access to their entire health record, including the physician note. And while many clinicians worried that such access would lead to confused or anxious patients, evidence from several studies has allayed these concerns. So the patients who are increasingly accustomed to managing their own affairs, such as traveling or finance, with the support of the digital system, are likely to demand a new kind of tools to help them with their own medical care and overall health. And many patients now keep personal health records, and these are increasingly becoming electronic. So the future developments in this area are likely to weave in the patient and provider-facing electronic system together, including information that are gleaned from the app and sensor, and facilitating a new kind of information flow and communication by email or text messages and even more, and also raising a host issue of surrounding the reimbursement liability, privacy, and data integrity about what happens when the provider and the patient disagree about what should be in the joint created report, and even more. So obviously, the BHRs can hold important implications for the patient safety, with even the capacity both for great leaps forward and some new hazards in the patient safety field. And the EHRs can raise yet another profound challenge, as the physician author has found that clinicians focus increasingly on the center of the data in the computer that are sometimes at the cost of the human connection that are so fundamental to the practice of the medicine and the art of healing. And after discussing the traditional approach to the patient, in which the patient body is the text, this researcher has found a more expedient approach that they see in the today trainees, that are the patient are still in the center, but as an icon for the another entity that are in the binary argument, the I patient. That often emergency room personnel have already scanned, tested, and diagnosed so that interns can meet fully patient long before seeing the real patient. So this eye patient blood count and immunization are tracked and trended like an index and then pop up with flags that remain the caregiver to feed or even to bleed the patient. So these are handily discussed in the card flipped option if the bunker, such as the conference room where the team does the work, or even while the real patient keep the beds warm to ensure that the folder bearing of their names can stay alive on the computer. So taking full advantage of the remarkable patient of the AHR or potential of the AHR is to improve the safety and the quality while also hitting the cautionary tale that may be one of the most subtle yet important challenges facing the caregiver in the modern age. So, what are the general characteristics of the reporting system? The error reports, whether filled on paper or even through the web, and whether routed to the hospital safety officer or even to the federal regulator, can be divided into three main categories: anonymous, confidential, and open. So the anonymous reports are one in which there is no identifying information that are asked of the reporter. And even though that they have the advantage of encouraging or reporting, anonymous system have the disadvantage of preventing the necessary follow-up questions from being answered. Where in a confidential reporting system, the identity of the reporter is known but is also shielded from the authorities such as regulator and representative of the legal system, for example, in cases of clear professional misconduct or criminal act. So such system can tend to capture more useful data than the anonymous systems because of a follow-up questions that can be asked. And the key of these systems, of course, is that reports must trust that they are truly confidential. And finally, in an open reporting system, all of the people and places are publicly identified. And these systems have a relatively poor track record in the healthcare because of the potential for unwanted publicity and blame that is very strong. Also, it is often easy for individuals to cover up their errors even with the mandatory reporting system. While another distinguished feature of the reporting system is the organizational entity that receives the reports. And with that in mind, let's first consider the local systems that are managed by healthcare delivery organization and the IR system. While before expanding on the discussion to the system that move the reports to the other entities beyond the clinical organizational walls. Another important point of consideration is the hospital incident reporting system. As hospitals have long had IR systems, but prior to the patient safety movement, this system received little attention. So the traditional IR system relied on a provider, nearly always the nurses. In most of the studies that showed that the nurses reports out the number of physician reporting by at least 5 to 1. This is to fill out the paper reports. While these are generally went to the hospital risk manager, whose main concern was often to limit their or institutional potential legal liability. So there was little emphasis on the system improvement and dissemination of the incident to other tools in the system, including other manager, caregiver, educator that were even unusual. While most of the clinicians felt that the reporting was a waste of time, and so few others did. And despite of the growing emphasis on the patient safety reporting, until recently, the reporting systems have been studied insufficiently. And based on a 2008 survey of the 1,600 in the US, the hospital errors, the hospital error reporting system has described 4 key components of the effective systems. And unfortunately, they found that the only minority of hospitals meet these criteria. In specific, only a small fraction of the hospital has showed evidence of a safety culture that encouraged the reporting, probably analyzing the error reports, and also effectively disseminating of these results and analysis. Also, these failures are not for lack of the effort or in many hospitals, the lack of investment, while in fact many hospitals have invested heavily in their IR system and mostly in the form of a new computerized infrastructure. However, the resources and the focus needed to change the culture around the incident reporting and also the management to probably analyze the report and to create a useful and durable action plans that have been less forthcoming. With that said, computerized systems do have their own advantage. For example, most systems can now allow any provider to submit an incident and categorize it by the error type and the level of harm, such as no harm, minimal harm, or even serious harm and death. So, in a confidential system, the reporter can be contacted by electronically to provide any additional details if it was needed. And a computerized system can also make it easy to create and aggregate statistics about these reports, even though that they are incapable of providing accurate error rates. So, as with other aspects of the digital data, increasingly sophisticated analytical and artificial intelligence systems may soon be able to mine the IR data to even identify a meaningful trend and to suggest even or implement a solution. And probably most importantly, the incident report can be routed out to the managers who are positioned to take action or even spot trends that are unfortunately not all computerized IR systems that have sophisticated of this function. And for example, when an error pertaining to the medical service is reported through a hospital computerized IR system, the system might automatically send an email to the chief of the service, as well as the service head nurse or the hospital risk manager and the category manager and the hospital director for patient safety. And each individual can review the error or have a discussion about it verbally or even over the phone or in person or even within the IR system computerized environment and document the action that are taken in response. And even though that this represents a great progress, it is important to appreciate the amount of time, the skills, and the energy of all of these functions that are required for such intervention. So many hospitals have built in or purchased fancy IR systems that exhort their staff to report every error and also the near miss or everything that they found themselves or overwhelmed by thousands of reports. So a system that generates a fewer reports but was also able to act on these reports can remotely and effectively would likely to be more effective than the ones that are far more reported than the end in the back hall of the hospital hard drive. So in addition, using informative technology to screen the incident and the report of the high risk events can be helpful in some of the cases. Also, as you can see, developing a thoughtful way to manage the data overload, whether the goal is to prevent the alert fatigue in a CPOI system or even to handle thousands of error reports in an overreaching team in the field of patient safety. And in an increasingly computerized environment and with the advanced trigger tools and other new methods of identifying the cases of error and harm, some of the patient safety experts are starting to question the role of volunteering error in reporting of the frontline personnel. For example, some can wonder whether every medication error and every fall can really need to be reported through the IR system. عفوا حصلت مشكلة في النت. لا لسه إن شاء الله مكملين شوية بس المشكلة في الإنترنت. So as we were saying, because most of the medical error can represent failure in the communication and the data transmission, a computerized medical record would seem like a safety lynch. So while the old term, the electronic medical record, is now replaced with the electronic health record, is generally preferred since it can emphasize on the role of the patient in viewing and even contributing to the report and the fact that the EHR can chronicle and even influence the health status, not just the patient medication and diagnosis. But we can also realize this benefit as attention must be paid to the variety of system and user factors. Also, system factors can include the ease of use, the speed with which the data can be entered and retrieved, in addition to the quality of the user interface and the presence of a value-added feature such as order entry, decision support, sign out, and scheduling system with link to all of the necessary data such as imaging and electrocardiogram and automatic reports. So the user factors primarily related to the training and readiness of the provider and the non-provider workforce, and both of these systems and user factors can play a role in the case of the septra of overdose described before. And the user efficiency is particularly important despite the hope that computerization would save time for the provider, as evidence indicates that the opposite is often true, in particular for the physicians. Also, many doctors can now complain that they have become glorified by the data that are to be entered, while also struggling to manage an overabundance of data and large volume of electronic communication with both patients and other providers. So all of this has been associated with troubling increase in the rates of physician burnout. And some of this cost in time may be repaid in more efficient information retrieval, but also increasing the attention that will need to be focused on the workflow. We should also remember that digital blood pressure reading in the wired hospital, where it can leap from the blood pressure machine into the EHR, where it can be seamlessly imported into each provider note and trigger useful decision support. An effective system will, of course, provide a huge efficiency benefit of the administrators, researchers, and the insurers by capturing the data in a standardized format and also allowing for the electronic transmission of these data. But unfortunately, the facilitated movement of bits and bytes has a dark side in the form of the copy and paste phenomenon. And one tongue-in-cheek of the easiest capture of the problem can be said as the copy and paste command, allowing one day note to be copied and even used as a template for the next day note. So ideally, old information and diagnostic impressions are deleted and the new ones are being added, while in reality, there is no deletion but only addition, with daily progress note becoming progressively longer and containing sensual information. Also, the admitting diagnostic impressions with long since discarded, which is definitely noted after the day. Also, last month, echocardiogram report can take up permanent residence in the daily results section, where complicated patients are on the post-op day for even 2 weeks. Therefore, one can wonder how the utilization of review can interpret these statements. Also, a cohort study performed in the ICU of an academic medical center found that copying and pasting of the note to be preventable among both the trainees and the attending. While in fact, almost 75% of the note examined more than one-fifth of the content of the daily progress note that was copied from the prior day note. Therefore, some IT systems can be disabled and the copy-paste function can be stopped, even though that this may be unacceptable to the provider, as some information really does remain in the statistic form from one day to another, and having to retype or redictate it is a wasteful and annoying. Also, resourceful providers can usually find a way to bypass such restrictions anyway. So in the end, copy and paste can resemble many elements of the patient safety in that introducing structural changes without ensuring the caregiver possesses the required education and professionalism is likely to lead to new types of mischief or even harm. Also, one important choice of the EHR developer is the use of a structured versus unstructured data. So the physicians in particular have always preferred entering data as unstructured rows. These were captured through typing, transcription service, or even increasingly speech recognition software, which has the advantage to ease into the use and familiarity, which is consistent with the long tradition of telling the patient's story. So on the other hand, unstructured data are difficult to analyze for patterns, therefore to use to support the quality improvement and the public reporting activities, and to also link the computerized decision support. In the structured or the coded data, these are captured by a template or even automatically fed into the EHR after being recorded by the electronic device. This can support these functions, but they can clash with the clinician mental model for the data acquisition and analysis. So the ongoing research is attempting to identify the best mix of structured and unstructured EHR input and to also develop new ways through a computerized natural language processing to mine the narrative process for the key data element. Also, one study performed in the Veterans Affairs Health System demonstrated that natural language processing algorithm could accurately identify the post-operative complications by screening the provider note. So this finding is supported by the additional research that is likely that the advances in the EHR of the future will be combining the best of both type of data to capture and to analyze, thereby decreasing the today documentation and information retrieval burden. Yet another important advances in this system is the ability to promote the patient engagement. So at the very least, allowing the patient to access their own laboratory data and giving them the ability to schedule their own appointment can represent a real progress in ensuring the patient commitment and also easeability of the care. So there are about 10 million patients in the US alone that have full access to their entire healthcare record, including their physician note, which has proved to be very useful in the care of the patient. And while many clinicians can worry that such access would lead to confused or even anxious patients, evidence from several studies has allied to these concerns. Also, the patients who are increasingly accustomed to the managing of their own affairs, such as travel, with the support of the digital system, are likely to demand new kind of tools to help with their medical care and their overall health. In addition to this, many patients can now keep personal health records, and these which are increasingly becoming electronic. So the future development in this area are likely to wave the patient and the provider facing electronic system together, including the information that are gleaned from app and sensor to even facilitate new kind of information flow and communication, such as emails and consultation via video. Can also be helpful in raising a host issue surrounding the reimbursement, the liability, privacy, data integrity, as what happens when the provider and the patient disagree about what should be in the joint created record, and even more. And obviously, the BHR can hold important implications for the patient's safety with the capacity of both the greater leaps afterward and some new hazards that can be implemented. Also, the EHR can raise yet another profound challenge, as the physician author Abraham Fergus has observed that the clinician focus is increasingly centered on the data in the computer, which are sometimes at the cost of the human connection, so that fundamental to the practice of medicine and also the art of healing. And after discussing the traditional approach to the patient, in which the patient body is the text, this researcher has found a new, more expedient approach that is seen in the today trainees to be implemented. Also, as the patient is still at the center, but is more of an iconic for another entity that is clothed in a binary garment of the eye patient, these often emergency room personnel have already scanned, tested the patient, and even made a diagnosis so that the intern can meet fully formed eye patient for long before seeing the real patient. So this eye patient blood counts and emotionals are tracked and trended like a Dow Jones index, and then pop-up flags can demand the caregiver to feed or even to bleed the patient. So these eye patients are handily discussed by the card flipped in the banker, which is the conference room where the team does its work. And while the real patient can keep to bed warm and to ensure that the folders bearing in their names stay alive on the computer. So taking the full advantage of the remarkable potential for the EHRs to improve the safety and also the quality while hiding the cautionary tale that can may be one of the most subtle yet important challenges facing the caregiver in the modern age. So what are the general characteristics of the reporting system? The errors of the reports, whether filled on paper or through the web, and whether these are routed to the hospital safety officer or even to the federal regulations, these can be divided into three main categories. They can be anonymous, confidential, or even open. The anonymous reports are the ones in which there is no identifying information that is asked of the reporter. And even though that they have the advantage of encouraging reporting, anonymous systems have the disadvantage of preventing the necessary follow-up questions from being even answered. While in a confidential reporting system, the identity of the reporter is known, but it is shielded from the authorities such as the regulators and the representative of the legal system, except in the case of a clear professional misconduct or a criminal act. So such system can tend to be captured more useful data than the anonymous systems because of the follow-up questions that can be asked and clarified by the reporter. And the key to these systems is, of course, the reporter must trust that they are truly confidential and they wouldn't be known. And finally, in an open reporting system, all people and places are publicly identified to all parties. So these systems have a relatively poor track of record in the healthcare because of the potential unawareness publicity and also the blame that is very strong, which is often easy for the individuals to cover up their errors even with the mandatory reporting if it was implemented. While another distinguishing feature of the reporting system is the organizational entity that receives these reports. With that in mind, let's first consider the local system that is managed by a healthcare delivery organization in the IR system before expanding the discussion to the systems that move the reports to other entities beyond the clinical organizational wall. So for the hospital incident reporting system, as hospitals have long had the IR systems, but before that, the patient safety movement, these systems has received little attention. So the traditional IR system relied on the provider, nearly always the nurse, as most studies showed that the nurse reports out of the number for the physician report as at least 5 to every 1 report. This is to fill out the paper report concerning the patient safety. So the reports can generally went into the hospital risk manager, whose main concern was often to limit his or her institution potential legal liability. Therefore, not all reports would be escalated to the right authority. So there was little emphasis on the system improvement and the dissemination of the incident to others in the system, such as other managers, caregiver, educators. That was unusual. While most clinicians felt the reporting was a waste of time, and so few did. Also, despite the growing emphasis on the patient safety reporting, until recently, the reporting system have been studied insufficiently. Therefore, this requires more research to be done in this area. And based on a 2008 survey in about 1,600 cases, hospitals' error reporting system has been described by 4 key components of effective system. And unfortunately, they found that only a minority of hospitals met these criteria. And specifically, only a small fraction of hospitals showed evidence of a safety culture that encouraged the reporting, probably analyzing the error of the reports and effectively disseminating the results of these analyses. So these failures are not for the lack of effort or in many hospitals, the lack of an investment. While in fact, many hospitals have invested heavily in their IR systems, and mostly in the form of a new computerized infrastructure. However, the resources and the focus that is needed to change the culture around the incident reporting and the management to even probably analyze the report and to create a useful and durable action plans have been less forthcoming in the recent years. So with that said, the computerized system do have their advantages. For example, most systems have now allowed for any provider to submit an incident and categorize it by the error type and the level of harm. For example, no harm, minimal harm, and serious harm, or even death. Where in the confidential system, the reporter can be contacted electronically to even provide additional details if it was needed. So the computerized systems can also make it easy to create aggregates statistics about the reports, and even though that it is important to re-emphasize that voluntary systems are incapable of providing accurate error rates depending, of course, on the case. And with other aspects of the digital data, increasingly sophisticated analytical and artificial intelligence systems may soon be able to mine the IR data to even identify meaningful trends and to suggest, in most of the cases, implement solutions for the errors that occurred. And probably most importantly is that the incident report can be routed to the managers that are positioned to take action or even spot trends that are unfortunately not at all computerized in the IR system that have this functionality. So, for example, when an error in the pertaining to the medical service is being reported through a hospital, the computerized IR system and the system might automatically send an email to the chief of the service as well as the service head nurse, the hospital risk managers, and the category manager, with also the hospital director of the patient safety. And each individual can review the errors, have a discussion about it verbally or even over the phone or in person, or either within the IR system computerized environment with documenting the action that was taken in response to this report. And even though that this represents a great progress, it is important to appreciate the amount of time, the skills, and energy of all of these functions that are required. Therefore, many hospitals have built or even purchased fancy IR systems that exaggerate their staff to report everything, such as error, near misses, and found themselves overwhelmed by these thousands of reports. Also, a system that generated fewer reports but was able to act on these reports as promptly and effectively would likely to be more effective than the one with far more reports that end up in the black hole of the hospital hard drive. So, in addition to this, using informatic technology to screen the incident report for the high risk event may be helpful in some of the cases. And as you can see, developing a thoughtful way to manage the data overload, whether the goal is to prevent the alert fatigue in the CBOI system or even to handle the thousands of error reports which is an overreaching theme in the field of patient safety. So in an increasingly computerized environment and with the advent of the trigger tools and other new methods of identifying the cases of error and harm, some of the patient safety experts are starting to question the role of the voluntary error reporting by the frontline personnel. For example, some can wonder whether every medication error and every fall really need to be reported through the IRS system. So perhaps we should be sampling the common error categories in the depth for the cohort periods of time, considering, for example, a system in which the January is fall month and February is pressure ulcer month, and so on, for more focusing on the errors that are likely to occur and developing interventions to help in preventing them. So a summary of what we have learned today is the definition of patient safety, the framework for program development, including the AC that are required organizational practice, the provincial legalization, and the organizational initiatives. We also learned about the framework for managing the change, including challenging the assumption, the sense of urgency, the humoring resistance and the readiness, and also sharing the story with the SMART goal setting and also improving the model framework, such as the rapid cycle test of change. So, as a closing remark, we cannot change the human condition, but we can change the conditions that are under which the human can work or perform. Thank you for your time. This will be all for today. We will see you again tomorrow, inshallah. If you have any questions, please do send them on the chat. العفو، بالتوفيق. الله يعافيكم. اللي كتب اسمه في التحضير يقدر يغادر. الله يعافيكم، بالتوفيق جميعا. بخصوص استفسارات التحضير تواصلوا مع الدعم الفني على الواتساب بخصوص اللي أمس ما حضروا يعني أسماءهم. بإذن الله السلايدات كلها والمراجع حيتم إرسالها لكم بكرة بعد الانتهاء إن شاء الله. التحضير إيوه مرة واحدة بس كل يوم كفاية. الله يعافيكم، بالتوفيق. ايوه التحضير مرة واحدة حتى لو خرجكم النت.